Today, it's such an honor to be here again, as Dr. Rubiano said, in your beautiful country and certainly your beautiful city. As Dr. Rubiano said, just for 5 or 10 minutes, I'd just like to tell you a little bit about the WFNS that is sponsoring this and what it's all about. First of all, a quick greetings from my hometown, Atlanta, Georgia, a city well known for the Civil War and civil rights. From Children's Healthcare of Atlanta, my home institution, which started from very humble beginnings. It's now got this large, big hospital that we're about to move into. We have a translational lab, and I'd like to thank all my co-workers. And just tell you all that I have no financial disclosures to tell you about, and all patients' pictures are given with their care. Once again, to Brenda, Amit, where are you? Amit, thank you so much. Dr. Gupta as well, and your committees. You guys have just done such a fantastic job, and I've had flashbacks to the meeting in Bogota 2 years ago when you made that great presentation, and here we are today. It's been a wonderful journey, so thank you. Thank you also to Mario and Andres for putting on this fantastic course. I appreciate you both very much. Thank you. So real quickly, for those that don't know, what is the WFNS? Well, real briefly, it is the umbrella organization for all 30,000 neurosurgeons worldwide on all 5 continents. It's not new. It kind of started in the 1930s, but really was formalized in 1955, and in different sections, which are not important to go into, but just to tell you that one of the key sections is the neurotrauma section that's represented by so many people here today. As said, the history is quite long. There are the icons in our field: Cushing, Sherrington, and Welch. And the question is, why are we here? And the reason that we're here is that Louis Pasteur said it best: science knows no country, because knowledge belongs to humanity, and it really is the torch that illuminates the world. And we are so grateful to be here, to learn from you, and to share with you, and maybe even illuminate with you. My term as a chair, I was honored to have so many people involved the last 2 years, co-chairs Andres Rubiano and Laura Lipper, and many people in the audience today, and I'd just like to give a shout out to Corrado, Salvatore, Brenda, and I don't know if Eve is here yet. I know she's on the way, but so many people that contributed to this wonderful 2-year stint. I'm not going into much detail about the history, but except to say that the main event is the annual conference. Used to be every 4 years, then the war interrupted, the Second World War, London, Copenhagen, all continents of the world. And the first post-pandemic conference was in Bogota, and that's where we elected to have this IGRANT conference. The last one was in Cape Town, also a huge success. Real briefly, we didn't follow an empty vacuum. We followed giants in the field, and I'd like to thank, even though they're not here, Tariq Khan and Peter Hutchinson for navigating the committee through the COVID period. COVID period was really tough for them, tough for us. We all learned a lot. We learned that neurosurgery is really not divorced from societal issues at large. We've all had our own experience and our own stories to tell. Mine is, just in case I need a reminder, this is our first case, a little child who's got unusual bruising, hemorrhages of multiple etiologies and ages, multiple rib and extremity fractures. The second case is a child who was involved in domestic violence. This was the entrance wound, there was the exit wound. Can't show you her face, but this was a very unsuccessful attempt to save this child by me. She died. This is our COVID years. This is child abuse. You can see how just increased. Likewise, gunshot wounds. And unfortunately, we all went through the COVID period and came out with these lessons. All of us here, Brenda, Mario, myself, Andres, Corrado, Salvatore, are very passionate about trauma. So why neurotrauma? Well, first of all, neurotrauma is not new. It didn't happen yesterday. Hippocrates wrote about it. A lot of groundbreaking research was done on saline and other therapeutics in the 1990s. And I really think we're on the dawn of a new age of neurotrauma. A good summary, and for those students in the audience, if you're going to remember one slide, I want you to remember this. This is from the Lancet. Andrew Moss was the first author, a multi-author study. But these two graphs here, my pointer showing, these two graphs here is traumatic brain injury. All the other pairs are other neurological problems. This is Alzheimer's disease, this is stroke. So you can see how important these two, traumatic brain injury, is. We see it in children worldwide. 70 million people are affected. And again, for me, what's so exciting, we're about to enter the stage of precision medicine. Right now, all patients are treated equally, and I think that that's about to change, hopefully sooner than later. Like I said, we had a fantastic committee. We followed on the post-pandemic COVID committee, and just like Mandela says, we got back on our feet and recovered and restored. Again, 33 members from 29 countries. And I'm going to go through the next few slides at a dizzying pace because I really do want to keep to my time limit. But I also want to just give you a smattering of what we do so that you can get involved. This isn't a show and tell. We want you to get involved. Call Dr. Sinha, call Amit Chakraborty and get involved. Our focus is education, research, really reaching out to those in need, and consensus statements. And here's some examples. This was the ICRAN conference that we had in just last year in Bolivia. The previous one was in Pakistan in 2019 by Dr. Khan. And here we are in India, thanks to Dr. Sinha's efforts in Jaipur. Next year to be decided when it's going to be. Some snapshots from Bolivia, wonderful scientific and cultural events. And here's the slideshow from it.
Hay elementos que son dinámicos y hay elementos que son estáticos.
So I won't play you the whole thing, but there's Corrado and Andre speaking. This is Dr. Rubiano getting an award from the mayor of Santa Cruz for the efforts of spreading the mission of traumatic brain injury. We've had meetings with all the major societies around the world, the neurotrauma meetings, WFS annual meetings, educational meetings before, such as this one, which was held in Guatemala City. And most importantly, we've spread the gospel, if you like, spread the news through the efforts of Dr. El Gondor in Egypt, where we reach up to 1,000 participants at a time with our 3-hour lectures of various topics of neurosurgery. This one is in neurotrauma, this one is in pediatrics. We have experts around the world. This is Dr. Failings speaking about spine injuries.
So I'll be speaking to you briefly
one of them asked about the use of steroids in the first week, the use of steroids.
Another world expert, Yves Stein, who spoke. And one other thing I'd like to just show you, which I thought was quite innovative and interesting, because of COVID, our Chinese colleagues could not travel much. So with Global Neuro, we partnered and had a 3-month weekly lecture series, which was both in Mandarin and in English. And I'll show you how that works.
My name is Laurita, and it is my distinct pleasure to welcome you all today as co-chair of the WFNS Neurotrauma Committee to this Neurotrauma lecture series. Our committee has been planning and dreaming of this lecture series for quite a long time, and we're very grateful to Global Neuro for allowing us to turn it into reality and hosting us for the next few months. I am confident that
Oops. Maybe just do this.
各位学员，尊敬的讲者，大家好，我是 Laura Lipa， 非常荣幸作为 WFNS 神经创伤委员会的联合主席，在此。
So those who know her know that Laura is a very talented person, a very talented neurosurgeon, but no, she cannot speak Mandarin, and she didn't learn it so fast, so we had this translated with just the click of a toggle button so it can be viewed and expressed it to our Chinese colleagues. Thanks to Rubiano, we've done some bootstrap studies, some multinational studies in spine. We partner with GeoTBI. Many individuals approach us and we help as we can with their research activities. I'm involved in a child abuse consensus statement, which should be finished soon. We endorse others. We reach out to the conflict areas, such as our colleagues in Ukraine right now. And again, I apologize for going so fast, but I hope you get the message. A lot is being done, education, research, and reaching out to those in need. So with that, I'm going to conclude by saying our aim, the WFNS, is to be a conduit for you, the worldwide neurotrauma community. We are here to facilitate any personal, regional, local, or global initiatives you may want to embark on that are going to better the lives of neurotrauma victims. And with that, I say thank you very much for your attention. Thank you so much for inviting me.
Professor Silva is going to talk about the impact of pre-hospital TBI outcomes. Thank you very much.
Good afternoon to everyone. And I want to first thank Dr. Andrew Rubiano, Dr. Reisner, and all the faculties for coming and hosting this meeting. It's a great effort of Dr. Rubiano. And my topic is EMS impact on pre-hospital TBI outcome. So we all know that neurological problems forms 1.7% of all the cases, and trauma constitutes 40%. It's a very major part of the neurological problems. After trauma, it comes the stroke, 33%, which is gradually every day increasing, and tumor, 14%. And it has been seen by WHO that if we don't concentrate on this trauma, Reisner already spoke so many things about the why it's needed. It will be 5th leading cause of death in 2030. So if we see the trauma system from resuscitation to rehabilitation, there are 4 phases: pre-hospital, in-hospital, in-hospital definite care, and rehabilitation. All these stages are very important. But pre-hospital is very, very important stage to prevent the further demise in the trauma victims. So pre-hospital care is outcome of results are definitely better in Western countries if we compare to India or any developing country. And it has been seen that there are 3 times more mortality rate in developing countries. This is an India study which says it is 3 times more death compared to US. it was because of difference in outcome due to absence of pre-hospital care and delay in admission. It means EMS is very, very important part. And it's a backbone. Pre-hospital care is a backbone of trauma system. Just mortality can be reduced by appropriate expeditious intervention in pre-hospital phases. It has been seen that 20% of the patient, they die on the road or in the emergency because they are not given very good pre-hospital care. So definitely pre-hospital care improves the patient outcome by providing good airway and blood pressure maintenance. And in some cities where the pre-hospital care is good, 90% of mortality has been reduced to 40%. And in past, we have seen in India also, because of effort of government and so many private sector, the improvement in outcome of the patients. It also facilitates the time the medical and surgical intervention. As far as the burden is concerned, is who's in the developing countries, and it is increasing. And it is because industrialization, socialization, people don't follow the rules, road safety rules, and don't follow the road safety rules. And there is not only death, but after trauma, the patient who suffer the disability, that is more dangerous or bad for the family and patient as well. Incidence, the current understanding of TBI in India and LMIC is limited due to lack of good based information, because we don't have any registry system in our country. So whatever information we get is either from police or fire or from different sources. So we don't have good data system which is present in all high income countries. And because of the good data system, they know where the problem, so they improve in that part and improving the mortality or outcome of the head injury. In this effort, in our hospital, SMS Medical College, we conducted a data collecting system for 3 years continuously from admission to discharge, and about 1,500 cases we are included in this study and this analysis, and hope we will improve the outcome of the patients in our state by after results of this study. Now, who suffers more? It is youngsters' problem, usually who are young, and so we have to work a lot for, because they are in bread and butter of the family. In our study of EDH and HDH, we have seen that it is mostly in third or second decade. And as for the Bangalore study, also NIMANS, 71% of the patients, they are between the 20 to 40 year of the age. This is our own institute study, SMS Hospital, that of 830 cases, most of the patients victim of head injury are between 20 to 40 years of the age. Pattern of the head injury is same. Either India or you go to Western countries, concussion the incidence is same. But severity is more in this Western countries because the different pattern of the mode of injury, because they are high speed. And as far as the multi-organ involvement is more in Western countries because high-speed vehicle accident. In our state or our center, it was 10.5% multi-organ involvement. Pre-hospital care. There is no organization in developing countries and low-income countries, and other is basic life support, which is there. Just where the technician is there in the ambulance or system, he just keep alive the patient till patient reaches the hospital. In advanced life support, this invasive patient, the patient intubated, IV line is there, so definitely is better care. In doc care system, doctor is escorting is the best care system for transporting the patient from site of accident to hospital. Now, what is the objective? Objective of providing EMS care is to improve the outcome of the patient. So, whatever injury at the site is not increasing during transportation, it means secondary injury we reduce by this. And all patients get the same treatment. In India, there is not only diversity in the landscape or geographical condition, but also there is a lot of diversities in the places. In metropolitan, we have very good medical system assistance for the accident victim, but in remote area, still there is absence of these good systems. Just I will share few of the countries like this Thailand. There is pre-hospital services are very difficult, and patient safety to hospital improvement by EMS is very critical component. They don't have very good system, and we know that most of the road traffic accident they lead to 90% of the disability. Now we come to Indonesia. Indonesian legends are here, consultant. It is a country of islands, 625 islands, what I remember. But there is no clear-cut system of diverting the patient from accident scene to hospital. Now we come to our neighboring country, Pakistan. In Pakistan, there are ambulances. While in other places, Latin America, if you compare, Latin America is also a very developing country, but because of the continuous effort of training to AMS system, they have improved the outcome of the patient. But in Pakistan, utilization of the ambulances is very low. Now we come to another country, developing country, like Nepal. This is our neighbor country. It is a lot of geographical, very adverse conditions, and hardly there is a road or transporting system. Sometimes these people, accident victims, they are carried on the back of the man or animal. So this is the scene still there. On the good side, we come to Malaysia. It is also a small country, but because of continuous EMS training courses and efforts of the country for good pre-hospital care, they have improved the outcome of the head injury. Just I will share my experience of Taipei. I just witnessed the accident at 11 a.m. and 11:20. Patient was shifted to hospital in the ambulance. This is I victim and with me our president of the National Neurotrauma Committee was also there. So if we see this golden hour, if we talk about the golden hour, now this is platinum hour, but in India, 24% of the patients only transported to the hospital. While 20% of patients, they don't even carry to hospital in 24 hours. So, pre-hospital assessment and treatment by first responder are critical steps in initiating safe and appropriate care of the patient. EMS is very, very important. There is an urgent need for making the EMS staff. This EMS staff or training can be given to police, to driver, taxi drivers, the person who stay most of the time on the roads. We can train them in a developing city so they can help transferring the patient from accident site to hospital. The first responder promptly give first aid. First aid can be given by anyone. We don't need a degree or license or certificate. So this is very important to train few persons so they can help on the side to transfer the patient to the hospitals. This is our study of 830 cases. Medical treatment 0. Most of the patients, they are transferred to our hospital by member of the public. This is the condition still when we are developing in so many sectors in our country. So this trauma is a neglected disease of modern developing nation. And until government political will is not there, we can't do anything, and we need to have political will with us. So to improve the care patient, by EMS staff has to identify, prevent, and treat clearly at the site of the accident and transferring the case. So in this effort, Dr. Dhaval is here. Our National Neurotrauma Society, our National Neurological Society developed these guidelines, and we hope that we will disseminate them to government. We are giving to the government, and they will disseminate to the different neurological centers. So the impact of injury is there, but it can be prevented and reduced. How? By effort of early transportation. EMS staff can do it, and otherwise millions of dollars is burden on the family, or rupees on the family and caregiver and on the hospital also. So we must develop evidence-based guidelines. Evidence-based guidelines is difficult in our country, but we can have this experience-based guidelines. So which reduce reactive variation, increase efficiency of healthcare, align clinical practice with evidence by reduce use of ineffective harmful therapies, increase use of the effective therapies, and improve patient outcomes. There is significant decrease in the mortality and disability by adapting the standard guidelines, which we have seen in US, where 51% mortality has reduced to 20% by the use of guidelines. So this is very important. So systemic efforts will lead to accurate diagnosis. Unfortunately, there is very little scientific publication. Most of the accidents are in developing countries, but most of the literature is from Western countries, not from our developing countries. So we try to make these guidelines in our state help for road traffic accident, or in country also. So we did study the US and European guidelines, and as per the local conditions, and we develop these guidelines as I mentioned before. As I told, most important is awareness program. Awareness is very important, so people follow the road safety rules. They must be educated. Enforcement is very important. So for this, we can use these celebrities. We can put the holdings for the road safety measures and all. So in this concern, we have all the highways, which are now new highways. They have all these facilities, which definitely helping to prevent the highway. They all the accessories which can help at the time of the accident. So in most of the places now in our country, accidents are in rural places. It is shifted from urban to rural places. Accident number is shifted. So we are using involving the family people of the accident victim to give the message for the road safety rules. Police, audio visuals, and as I told, holdings, we put some time. And in helmet also, we have made compulsory in Jaipur with my transport commissioner and media, Bhaskar. So we all worked and we made the helmet compulsory. After that, the mortality of in Jaipur city dropped down from 42% to 21%. So this was our effort for this, and this is another effort from which we had in form of rally. The small children giving the road safety measure for road safety measure. She is an accident victim, giving awareness message to the audience: use helmet and follow the road safety rules. And these rallies, we have the number of rallies in our city and different cities we have planned, and this rally was flagged off by Dr. Janet. Then this is all the film stars. Our Amitabh Bachchan is a Bollywood star, which we used involving for the road safety rules message. These are papers. So finally, I want to tell that every campaign should have stop for help, call the help, assess the victim, start the breathing, stop the bleeding, and every vehicle should have first aid box. so we don't have to run here and there. So for current communication, there is a law of uniformity on the phone number. One road has different phone number, other highway has different phone number for in case of emergency. So we should have uniform phone number all over India, which is lacking. And there is a not good communication between the EMS staff and local hospital, so which should be monitored and more drills should be there. We can use the GPS system here, we're using mobile. So all these systems should be used with central monitoring for good EMS system and the hospital. So what should the quality of EMS system? EMS system quality is first, if present, must able to dispatch the patient to health center, then should she or he should be skilled enough to know the pupil size, the pulse, BP assessment and all, and must know how to resuscitate the patient, how to start the fluid and airway management, and must be conscientious when choosing a hospital to which hospital patient should be transferred. And he or she must know about the management of individual victim, multiple victim, and developing countries, because we see all the transport system still existing in our country. Why this is a problem? Because affordable vehicles number is less. Roads are not good, but they are improving definitely, and financial problem. This is another problem in developing countries. So this is 108 ambulance we have in our state, which is working very nicely and efficiently. So we must start the treatment at the first site by EMS, and hospital where must be verified, should be known to EMS staff where patient should be transferred, and unnecessary referral should be avoided. And then I won't go in detail. The EMS staff must know the primary assessment, secondary survey, and while doing secondary survey, patient must be ready to transfer to the hospital, and pre-hospital, whatever the condition of the patient should be informed to the referred hospital. So airway management is important. We must use least invasive manner, and if there is short distance, we can use the bag mask, this mask. Intubation is definitely helpful, but it's difficult. There are two indications where we can use the intubation, and definitely it improves the outcome from 36% to 57%, and or mortality decrease from 57% to 36%, and but the injuries 70% are also reported. And so that, as I told, these masks are very important. All the 108 ambulance carrying these masks, which success rate is 81% compared to 57%. So oxygen management, pressure management, GC scale should be known by the EMS staff. EMS staff should know the GC assessment in the pediatric age group, pupillary examination, and size and shape and all. Fluid management should be known by the EMS staff in adult what to give, in children what to give, and if there is herniation, if ALS system is there, patient should be taken on ventilator, but prophylactic hyperventilation is not recommended, as literature says, and we all understand this also. So just I want to take a few minutes more. This is our project we launched in our state to improve the outcome of the head injuries patient, so giving the good pre-hospital care. So we have these highways coming from our city, Jaipur. So on the all highways, we went to all the crowded area, the most prone accident. We went there, we trained there the people how to examine the patient, accident victim, how to transfer, how to contact the hospital, and this is our all the efforts. And we know that laymen don't know what immobilization, what is this all, so we have to teach them. So this was our effort, and we established the first aid post. on number of highways. So we have given them the first aid material also. So they were using this material for accident victim. So this is they were all offered. So this is hospital care we are doing. So just finally I want to tell the correct identification of TIA is important. Optimal treatment in ambulance is very, very important. Direct transfer of TIA patient to trauma center should be done, and optimal, prompt and cost-effective care can be offered. And our goal is to get right patient to right place, to right time, and to receive right care following the trauma. Thank you very much.
Before pandemic in India, here in Jaipur, I noted how old people is wearing helmets in the motorbikes. For me, it's very special point of view. I mean, I know how your efforts are made about the campaign for helmets. We saw a lot of time ago the movie, and I was some years ago before, so for me it's much more apparent the difference, and it's a real difference. It's not, of course, in the whole country, but here in Jaipur I noted how old the people are wearing the helmet. The main part.
Yeah, I told in my before also. For this, I connect to our transport commissioner. I don't Dr. Rohit Bhajan. He was very positive for worried about this accident. So police is very important. Second, media. Media can change anything. So we all work together. We put the logo of posters in the city. Helmet is necessary. Why helmet? Keep your family happy. Wear helmet. So we did campaign for a month. Then helmet was made compulsory by government. So we made the helmet stuff. So then it was made. So this was our effort, and definitely it helped us.
I'm witness of your success.
The podium again, Professor Rubiano, on his next talk, review of new trends and guidelines and protocols. Thank you very much.
Okay, thank you so much. So I think after this very complete presentation from Professor Sinha, we are gonna attach this topic related to focus a little bit more into the concept of the clinical practice guidelines. I want to highlight that most LMICs, there are not a specific pre-hospital care guideline for TBI. The main two efforts that already have been published are actually India and Colombia. So we have that in common, that we have guidelines for the country, proposals, and it's really interesting because we obviously have international guidelines in high-income countries, especially the BTF guidelines. You know that the third edition was released recently, but we all understand that clinical practice guidelines are documents that incorporate recommendations mostly based on evidence, sometimes based on expert consensus, that try to reduce the heterogeneity in the clinical practice. It was seen in the past presentation that there are many regions that do not have the same conditions in order to take care of the patients. Generally, when you do these efforts, there are robust methodological approaches that try to obtain the best evidence available. But when you do that, there is a lot of gaps because, as was mentioned, there is not too many research in the field. So the limitations for most of these guidelines are that they establish rigid recommendations that are generally not very specific, and there are gaps when you go to the real-day practice. So in order to fill these gaps, it's necessary to translate these recommendations into clinical practice, and additionally to the recommendations, regularly there need to be some consensus of experts that build protocols with flowcharts and algorithms that can be usable in the real practice. So when we will move from guidelines to protocols, consensus algorithms, and flowcharts, we need to understand that this consensus generally arises from the agreement between professional experts. The protocols establish a series of procedural steps or agreed rules in order to provide care in specific health situations. And the algorithms allow the decision-making flow in these protocols, and it can be introduced in another documents. Sometimes these terms are interchangeable, but really everyone has their own function into the process. When we talk about management of patients in areas that do not have too many resources, there are several conditions of the context that need to be taken into account. Geographical conditions, financial conditions, knowledge conditions, infrastructure conditions, social resources, influence and belief of the culture around, human resources limitation, and sometimes problems during the healthcare delivery. So there are so many factors that at the end affect the process of care. With the WHO, it has been established that if you improve pre-hospital care, you reduce mortality. It has been mentioned before. But the question is, are you able to have, in all regions of the world, organized pre-hospital care? Because you can have pre-hospital care, but sometimes that care is not organized. So from the WHO perspective, it has been proposed this emergency care system framework that have many of the actors, many of the integrations between the pre-hospital, since the field and the emergency rooms. And definitely there are a lot of barriers that allow breaks or breaking points between these cohesion steps. As was mentioned before by Professor Reisner, this report from the Lancet Commission about TBI shows where are the gaps that affect the most TBI patients worldwide. And definitely, in LMICs, the most critical point is pre-hospital care. So if we do not work together in order to improve pre-hospital care, and we focus too much into the surgical care or even into the ICU care, we are not going to have really appropriate outcome. So that means a very important first point is why we are here talking about this, being mostly neurosurgeons, is because neurosurgeons have a very important level of providers. So we need to be very involved in training, in supporting training for pre-hospital providers and also for emergency medical services actors. We all know about the work of the G4 Alliance. The G4 Alliance is an advocacy group that works hand by hand with the WHO in some points like surgical care, obstetric care, trauma care, and anesthesia care. They have been doing some specific research into many of these fields, and in trauma care, there are 4 recommendations that are very basic that really can generate a difference. The first one is to implement pre-hospital trauma systems. If you organize pre-hospital systems where it didn't exist, it changed the mortality of the patients. It reduced the mortality and decreased the disability. Training first responders. If you really dedicate part of your time to train the people that is in those vehicles, that will reduce the mortality and decrease also the disability. Training trauma providers inside the hospitals and inside the emergency wards. If you participate also training people in these levels, it will reduce the mortality and decrease disability. And finally, you need to test if what you are doing is working. Because you can say, okay, I will do this and it works, but you need to prove it by science. So you need to implement trauma quality improvement programs in order to periodically evaluate if it's really affecting or reducing the outcome or reducing the bad outcome in these conditions. But what happened? We have been discussing this many times that one size does not fit all. So if we have some guidelines and we want to apply sometimes those guidelines at national level or a regional level or worldwide level, those guidelines didn't fit for every one of the regions because not all the resources are the same, not all the people is equally trained, not all the systems are equally organized. So how we are gonna go over these barriers? This is one of the proposals that we have been working on, and it's the concept of the stratified protocols of care. What is the concept of a stratified protocols of care? For example, if you are talking about, okay, how we can improve the management of patients in the ambulance, you need to know that there are gonna be very basic ambulance without resources, without training, and you are gonna have advanced ambulance with a lot of resources, a lot of training, even into the same city. You know, and we know that sometimes in the same city, we are working in a center that have completely level of resources to the center that is in the next block or something like that. And that affects all this process when you are talking about quality of care. So what we did was taking people that was actually working in centers of different level of resources. So we were working with physicians, nurses, paramedics that were working in areas that do not have any kind of resources, but they were managing patients. And we involved them to work with people that have been with some level of resources and also with people that have been in centers that have a lot of resources. And we put them together and say, okay, what are you actually doing in your center in order to improve the outcome of your patient? So we have to this scheme that is there in color that explains more or less how is the process. So if you are in a pre-hospital level, you can be in a center or in an ambulance that does not have nothing, or some ambulance that have some resources and some level of training, or ambulance that have very high resources and very high level of training. And then you move from there to an emergency room that can have CT or cannot have CT. There are patients that arrive with severe TBI to centers that do not have immediate access to CT. And even in those situations, you can be in a center with CT with very low level of resources that exists in those places. You have the CT, but you don't have resources to take care of the patient. Or you can have some level of resources or high level of resources in the CT. Or you can be in a center without CT, with very low resources, some resources, or high level of resources without CT. And then you can move to centers that can have neurosurgeons in place in order to operate the patient early. Or you can have centers that have operation room but don't have neurosurgeons. Sometimes only have orthopedic surgeons, or sometimes only have general surgeons, or sometimes even didn't have any surgeon, but they have an operation room there. And then if you operate the patient, you can move to an ICU with very high level of resources, or you can take your patient to an area that can be even the general ward because you don't have ICU access. Or sometimes you need to leave your patient in the operation room because there is no ICU available. So all this situation happens in the real life. And then, even in those conditions, you need to have recommendation for every one of those stages. So, thank you so much to Professor Amit, because he was very supportive of this idea. When we started working with this idea, we sent this manuscript to very high top-ranked journals and were evaluated by people from high-income countries, and they never understood what we did. So they say, why are you talking about managing a patient in a center that have high level of resources but doesn't have a CT? That is not possible. And we say, yes, it's possible. When you are in a center that have all the resources, you don't understand that in other regions of the world, there are centers that doesn't have all the resources. So after going and going and going in many journals, we have the fortune to have Professor Amit to understand the concept, and finally it was possible to publish the paper, because without that support, maybe this paper was never published, because the reviewer didn't understand the concept. So now the paper is published. The most important thing is not the article per se. The most important thing are the supplementary materials. Because in the supplementary materials, you have step by step each one of those protocols for each one of those stages of care. So, just a brief example. This is the algorithm for managing a patient in areas that do not have any type of resources. Like, if you are in a center that you only have the car, but inside the car there is nothing that exists in some regions of the world. You have the ambulance, but if you open the doors of the ambulance, there is nothing inside, And even there, you need to do something for the patient. So if you are in that type of a scenario, the only things that you need to do are the red blocks. That's the only intervention that you need to do, Very basic stuff like you say, like, why? Like, open the mouth of the patient to start breathing. It's pretty obvious, but in some places, you need to reinforce those concepts. If you have more level of resources, you do the red intervention plus the yellow interventions. That are, when sometimes in that type of vehicles, at least you have, for example, a BBM or a bus system in order to ventilate the patient. Maybe you don't have an endotracheal intubation possibility, but you can have at least mask bagging for that patient. So then you move to the yellow steps. This is the more advanced treatment, so you can do the red ones that are the basic ones that we already mentioned, plus the yellow ones that if you have more resources, and if you have more resources, and you have, for example, a laryngeal mask on an endotracheal intubation, and you have people inside the ambulance that is able to intubate the patient, you move to the green steps that complete finally something very similar to the algorithm that was published in the 3rd edition of the BTF guidelines. Because those guidelines are organized for areas that have all the resources. So in order to finish the idea, there are future trends now that have been learned for working in very difficult areas like the military area. We now unfortunately have conflicts all around the world. We have TBI patients in very bad conditions in areas that do not have too many resources, in the middle of the jungle, in the middle of a mountain, in an area that you have under fire and you cannot do nothing there. And there have been some learning points regarding using technology. We are now to discuss today some of those technologies that can bring you to some sort of better understanding of what is happening inside the skull of that patient, even in those environments. We all know are familiar with the human textbook, the textbook that we use for training the neurosurgeons worldwide. And we were very fortunate to have the opportunity for first time in the book, in the last edition, to write a chapter related to how to manage patients in this kind of environment. And we are integrating many of these technologies that we are going to discuss today as possible steps in order to have better knowledge of what is happening inside the skull of a patient in even areas that do not have too many resources. With the support of the NHR and the Cambridge group, we are now testing those protocols in a clinical trial. We are in this moment finishing the trial. We select different levels of scenarios. For example, in Colombia, we have hospitals that are in the Amazonian region that does not have nothing, And if you want to transfer that patient, you need to wait for a boat, 16 hours, moving the patient in a boat before arriving to an ambulance. And in some type of scenarios, you need to do something there. You need to have some sort of recommendation. And you cannot take the 3rd edition BTF guidelines to apply to that patient. So we are testing that type of scenarios, not only for pre-hospital, but also for emergency rooms, and also for surgical wards, and also for post-operative care areas. And we are going to have finally the results of these studies. So this is something that I really want to share after all these great summary that Professor Sinha did related to pre-hospital care in LMICs and in many different countries, and just to show that this is some sort of new trend that we can take into account in order to move with building all these different scenarios for taking care of the patients. Thank you.
So, our next speaker is Dr. Andrew Rezna, and he don't need any introduction. He is chairman of World Federation Neurotrauma Committee, and during his tenure for last 2 years, he has done lot of educational activities to enhance the trauma patient. Right? So, I invite Dr. Rezna, please.
Thank you. Good afternoon once again. It's a huge honor and a pleasure to be here. And honestly, a little bit humbling following your great talk and Dr. Rubiano's great talk. I don't know if Andres is still in the room, but there we are. Andres, I think I should have put the title here, biomarkers, perhaps the next step that's going to help TBI victims worldwide, HIC, LMIC, etc. And I'd like to elaborate on that a little bit. Before I do, again, a huge thank you to Dr. Sinha, Amit, and Dr. Gupta, and of course, Mario and Andres for this meeting. Greetings from the Neurotrauma Committee, which I've done. And let me just jump in and speak about TBIs. My focus in my practice is pediatrics. I only do pediatric neurosurgery, so forgive me a little bit if I have a little bias towards pediatric neurosurgery, but this applies as much to adults as pediatrics. Again, I'm referring to this.
We are not.
Oh my gosh. There we go. I don't think you've missed anything too important. So these are the outline of the talk, and let me get right onto it. Refer to this excellent article. Again, this time I've highlighted the TBI compared to other neurological conditions. In children only account for about 5% of TBIs, about 8% of 5% of TBI deaths, 8% of TBI hospitalizations. But as Verenda has mentioned, children are perhaps really important, especially when you consider these terms, years of life lost and years lived with disability. So that's important to remember. For those that do adult neurosurgeons, I always find it interesting how the very young and the very old falls, which are shown in this sort of reddish here, are most prevalent. As was mentioned in Dr. Rubiano's talk about the different regional differences, and there are different region differences with everything in TBI, including the type of injury that children have. For example, in India, as everybody in this audience knows, balcony falls are a problem. In Singapore, perhaps abusive head trauma is becoming more, and motor vehicle accidents. In the United States, we have gunshot wounds. Again, this talk has got a bit of a pediatric focus, and so let me just quickly say that children are not small adults. They are completely different animals. The brain expands tremendously, especially the first 2 years of life. But it's interesting that the number of neurons that you've got is the same at birth as always. It's just the neurons have more dendrites and more connections. The white matter, however, changes. A TBI can arrest any of those processes. So again, the pathophysiology is important. The other structural differences, kids have got small skulls, open fontanelles, There's greater water content in the white matter, and generally speaking, children tend to have more diffuse cerebral edema and less commonly the bleeding or mass effects from subdurals or intraparenchymal hematomas as adults, and vice versa. But of course, they both have both the swelling and the hematomas. Not surprisingly, there are different TBI guidelines, and I'll speak to that a little later, in children versus adults. So what is the potential role of biomarkers? So let me quickly stop right here. Biomarkers. I want everybody to hold up their hand that's used a biomarker. And I suggest everybody holds up your hand. If you've used a biomarker, hold up your hand. There's not enough hands. Put up your hands. If you've taken a blood pressure, you've used a biomarker. If you've looked at a chest x-ray and you've seen a granuloma or a tumor increase in size, that's a biomarker. So I want to quickly just dispel this rumor that, biomarkers are some fancy medical thing that's used. A biomarker is just like the name suggests. It's a marker of any biological process. A blood glucose for a diabetic, that's your biomarker. The one that we use and we speak to and that we wish we had in TBI is that what they have for heart attacks, troponin. That has revolutionized the diagnosis of chest pain. Is it an angina or is it a heart attack? And depending on the troponin level, you can make it. So a lot of people say to me, what about TBI? We don't really have a biomarker. It's important to diagnose angina versus a heart attack, but this guy's come with a knife stuck in his wound. This, God only knows what happened to this child. Nobody's going to say, what's the diagnosis here? We all know it's a traumatic injury. We all know it's a knife wound. Why do we need a biomarker for that? Well, the answer is we don't. What we do need a biomarker for, though, is to follow the treatment. What is the risk? What is the prognosis? How is it going to guide our management? And we absolutely need that. This comes from a track TBI slide. These people, adults, were all the same GCS, and you can see they're all different. They said epidural, they said contusion, subarachnoid, diffuse swelling, the same GCS, very different problems. Right now with neurotrauma, we don't have precision medicine, we have imprecision medicine. There have been 40 at least failed trials, and we need to move to this precision treatment where we're going to have successful trials. Different head injuries occur in different people. And as Dr. Rubianos discussed, at least with me privately, and suggested, in your lifetime, pretty soon, next 5 or 10 years, the Glasgow Coma score is going to have less value. It's going to be a new classification system based on the clinical findings, yes, the GCS, but also the biomarker, imaging, and environmental, CBIE. That is the new classification that's being worked on at the moment at the NIH. There's a big meeting a couple of months ago, and expert panels are working on this particular classification. So what's the big deal about TBI biomarkers? Well, let's dream for a minute. What can a biomarker do? It can triage effectively. So we got Virendra, he's speaking about the EMS, and all the people that come to you. How do you know which ones need to come fast and you don't? Imagine if we had a biomarker, like a blood glucose, and I'm going to call it the Dr. Sinha biomarker, just in your honor, and let's say it was high and they needed urgent treatment, well, you'd urgently transfer them. But I don't know about your institution, but in my institution, so much money is wasted and so much resources is wasted sending people that really didn't need to come to a big center. People that had maybe a post-traumatic seizure or they were misdiagnosed. But again, if you had a biomarker that could tell you how bad the head injury is, wouldn't that be wonderful? We just don't have it. Do you need to do a decompressive craniectomy that Corrado's worked on, early or late? I mean, there are just so many things that potentially this could answer for us. So we need a biomarker, and we need the ideal biomarker, which is biologically stable, easily accessible, inexpensive, reflects ongoing physiology, rapidly can be measured at the point of care, and specific to the brain. The problem is we don't have that yet. We don't have that yet, and we're working on that biomarker. A lot of studies have been done in adult studies due to center TBI and tract TBI in North America, many other organizations, the CDC, the Brain Trauma Foundation, have focused more on adults, a little less on kids, but that's changing. Regardless whether it's adults or children, we look at biomarkers that come from the neuron, the glia, the axon terminals, and blood-brain barrier, and my interest, the microglia, which is the inflammatory cell in the brain. We look at one particular substance called osteopontin. We did it in animal studies in my lab first. We found it was elevated. We then did it in clinical studies, and these are the nurses monitoring for us, admission 24, 48 hours. And what we found is that the osteopontin was a good marker, not the ideal marker, but possibly a good marker. And out of that, we got an NIH grant. We did a bigger study. The results are not finalized, but we found that it did predict as much as the other commonly studied biomarkers. We published this, we just had our first paper published. And here are a couple of patient examples. This is a kid that was run over by a car. A massive injury, was kept alive only for organ donation. And I know that's important to you, again, for organ donation, but you can see how the GFAP, one of the markers, stayed low, but the osteopontin increased during the 3 days while they kept the patient alive before they could procure the organs. So that was an interesting thing I'll share with you. Another interesting thing for the pediatric neurosurgeons, a big problem we see is abusive head trauma, and we found that the osteopontin or inflammatory marker was much higher in kids that were shaken than kids that had the same injury from just a single motor vehicle accident. They are doing pediatric biomarker investigations. There's some regulatory and financial challenges. The FDA hurdles are higher, less industry support. The amount of volume of blood we can get from children are less. There's a limit to how much blood you can get, especially from the small kids. In pediatrics in general, the trials are just cumbersome and difficult. And it's interesting, and I'll go to the next slide, that of the ones that were registered by the NIH, only 40% that got NIH funding ended up in a publication. So most of them get stopped because of the high logistics, the complexity, keeping the patients engaged, etc. We neurosurgeons don't do as good a job as my oncology colleagues. All children that come in with brain tumors or leukemias or other kinds of cancers are enrolled in trials, almost automatically. An example is this kid I was called out in the emergency room, coming with this child, is in coma, he's got bruising, bleeding, probably is abused, he was bleeding out the nose, some rectal bleeding, probably sexual abuse as well. So we took this kid quickly to the CT scanner, and yes, he had hematomas, but didn't look like child abuse, just a different pattern. And as we in the CT scan, I get this call from our resident. Here's the result of the CBC, the blood count. The white cell count was over 400,000, and this child ended up having leukemia and was enrolled in a trial the next day. Other challenges preclinically were getting the right animal model at the right age. I've given an example of how oncology does it better. When we do cross-national trials between HICs and LMICs, there's really important cultural issues that need to be taken care of. And I think this article that appeared in the Journal of Ethics says it best. Ethical approval in developing countries is not optional, and the ethical approval is really difficult because of cultural barriers. If I could have one wish list, it would be that we don't have the normal values defined for children as we do in adults, this is the different biomarkers in minutes, hours, or days. We just don't have that yet. But once we get the biomarkers, we know the role, then they can be incorporated into guidelines. And we've spoken about the importance of guidelines. I'd like to tell you that this is my idea. It's not. It's already been done, especially in Scandinavian countries with concussion and mild head injuries. I took this slide from without permission, so maybe I can get permission now from Dr. Rubiano to use this picture about his resource-based guidelines. Biomarkers that were inexpensive could be helpful there. I'm going to finish off with this slide. I really wish my friend Franco Cervide was here. Because Franco Cervide always says to me, oh, but biomarkers, it's a high-income country thing, it's expensive, it's going to cost a lot of money. What are you saying? What about LMICs and low-resource countries? And here's my answer to Franco. This slide is the cost of your chip in an iPad number 2. That's how much it will cost. This is greater than the budget of India and the United States put together. Trillions of dollars. Right here, in the 1950s and 60s. Trillions of dollars for that chip. You couldn't buy it. It wasn't available. Then the space race came and came down to the billions and then the millions. And as we all know, we can, some of us, most of us can afford a little personal computer. It's come down to the hundreds of dollars now as a chip. And I have no doubt that that will happen to the biomarkers as well. The cost will drop as the technology improves, and also the technology to get biomarkers results immediately. We have this iStat, I don't know if you use it here, but just a simple glucose thing, and they've now developed an iStat, and we may be trialing it and doing some research to see if that can give us the level of biomarkers at the person's bedside immediately. So I think there's a great future for biomarkers. The cost of technology will drop. The technology is improving so that we can get point of care. And I'm going to conclude by that by saying more robust multi-institutional studies are needed with safeguards crossing barriers. And I think that the future looks quite bright, and hopefully we will manage TBI patients more effectively down the road than we are right now. Thank you very much.
Excellent talk, Andrew. Can I have a question?
Of course.
So what is the experience with S100 in children at your hospital? Are you using it or?
Yes, we were confident with our results of S100. In fact, of that NIH grant, that was our first publication looking at that inflammatory marker in S100, and we find that it is very valuable predicting the 6 to 12 month outcome, long-term outcome in children with TBI.
The reason why I'm asking that is my view is that the future belongs to multiplexing analysis. So S100 alone might only give so much information. Correct. And therefore I'm expecting a lot from, for instance, the work that are conducted in Birmingham in the UK by Tony Belli, or others in North America, you included obviously, looking at obviously different type of biomarkers coming from different sources, mRNA, coming from different type of sampling, saliva versus blood versus serum, etc., etc., and possibly coupling them with other factors to get proper biosignatures of TBI.
Yes.
And then,
no, that's our future. We had spent many years looking at saliva. We have collected about 150 patients.
yes.
Initially looked very promising. Further evaluation, not so much. And so we have not published on that yet. We're reanalyzing it before we publish it. But we'll see what comes of that.
Thank you very much.
Thank you.
Can I ask, biomarkers in children and adults, they are same results or there's a difference in?
They are the same, but the normal values seem to be different.
Okay.
So what's normal in adults, the kids seem to, especially younger kids, seem to have higher values. So if you say, oh, kid's got a high value, does it mean they have a head injury? Maybe not. It has to be higher than that. So the normal values change with age. That's the problem for every biomarker.
Thank you for an excellent talk. Partho Rai, neurologist, Kolkata.
Thank you.
I think you said that in your last part one slide as to how personalized medicine has taken over the entire field of hematological malignancy and even cancer genetics in the brain, gliomas and all the rest of it.
For sure.
What do you think is the limiting factor in us being unable to make such similar progress in the TBI field, be it in a pediatrics age group or in an adult age group? Where do you think the problem lay? Still, unless we are able to overcome that obstacle, we'll still not be able to personalize our TBI patients in all age groups. So what's your take on that?
I think there are many factors. I think, quite frankly, TBI has been ignored. It's just not the sort of sexy disease like a cancer that a lot of resources are put into. Secondly, it's a dearth of tissue. We may biopsy a glioblastoma to find out if it's a glioblastoma or not, or to grade a medulloblastoma. We don't really biopsy the brain for traumatic brain injury. I don't want to say it's more complex than tumor, but gosh, it is a complex problem. And it's an evolving problem. So what happens in the first hour is different from the secondary effects in the second, third, and fourth hour, and the whole pathophysiology is beyond complex. Again, I'm not trying to say it's not complex in tumor genesis, but it's infinitely complex in TBI. And lastly, there's just so much individual variation. As I showed in that slide, with different CT scans, they're all the same Glasgow Coma score. Likewise, you can have the same Glasgow Coma score of 3 or 4, which is very bad, and it always makes a fool of me. I think, oh, that kid's not going to do well. Guess what? They walk into my office 6 months later, and yet you've got a child or adult with a good GCS, 13 and 14, and they don't go back to work forever. So it's a complex problem. The last point I want to say, and for me, if I can share one thought with you, TBI is not an acute disease only. It's an acute and a chronic problem. And so something's happening, like Alzheimer's disease or chronic traumatic encephalopathy, an inflammatory thing probably, that just keeps the ball rolling, so there's this continued deterioration or lack of improvement. So I'm not too sure I answered your question.
Yes, it is. I think it's quite an intricate area, and you had lots of biomarkers and on your slides of possible biomarkers.
Right.
Could we have some score of all those biomarkers and maybe have a product which would be able to give us a better outcome data, possibly using some cloud-based platforms on the acute setting on an hour-by-hour.
Yes.
You had shown us pupils and CT scans and maybe the NFLs and the SB100s, and the sky's the limit. So maybe something along those lines as a predict. It's the most common disease, so how come we didn't think it was stimulating enough
Great
for the
question.
public perspective? Yeah,
Exactly.
even in America, in gunshot wounds, you said.
Oh, totally.
How come we neglected all that and got away with it so far? Any take on that? It's a political question. Okay, thank you.
Great questions. Thank you so much. Thank you.
Okay, now we have tea break of 15 minutes. Everybody has to assemble here after tea break. Please.
To speak about the role of the near-infrared spectroscopy in neurotrauma triage at the hospital level.
Good afternoon, everybody. I thank the WFNS Neurotraumatology Committee and Dr. Rubiano from Global Neuro and Dr. Vidi Sena from local organizer for inviting me to give a talk on this. So I do not have any disclosures. So these are the two celebrities. The man is Raman Lamba, which people of my generation may probably know. He was an Indian cricketer. And another is Natasha Richardson. She was a British actress. And there was something common between these two. So she was skiing in Canada, and after a minor skiing accident, she went back to her room and then was found in a comatose condition. And the another person was working at short mid wicket in cricket field, and he was hit by a cricket ball on the temporal region. He fell down, and after a few minutes, he got up on his own and walked to the pavilion, and at the end of the game was found in comatose condition. He was flown from Dhaka to Delhi. By the time he could arrive, he was brain dead, and autopsy revealed extradural hematoma in both the cases. So what could have saved their lives? So the cause of death in both of them was traumatic intracranial hematoma. So if a point of care device would have been available in the field, where CT scan is not available, which could diagnose accurately that there is something wrong going inside the head of the patient, and an urgent CT scan is required, both of them could have been transferred to hospital early, though apparently they were conscious after injury. So why do we need an additional device when we have good clinical prediction rules? This is a review of literature by me. Like, there are so many guidelines: American College of Emergency Physicians, Scandinavian guidelines, WFNS guidelines, European guidelines, and British guidelines, NICE guidelines. These are the clinical prediction rules. Like, the patient has head injury, and if any of these features are present, that low GCS or loss of consciousness, amnesia, elderly person on anticoagulants, and a number of other variables. So a CT scan is required. So we know that there are clinical prediction rules, but if you see the sensitivity and specificity of these rules, so they are quite sensitive, like 100%. Like, so that means basically you have to do CT scan for everyone who comes with head injury, which is not correct. So NICE is more conservative. It is very specific that if any of these features are present, 40% will have an abnormal scan, but look at the sensitivity, it is low. That means 18% of the cases who may have hematoma, following this NICE rules, you will not do a CT scan. So what happens with any of these clinical prediction rules is that they should be able to detect the entire patients at risk of intracranial injury with a minimum number of scans required to detect one positive case. So that means we need something else besides clinical prediction rules, which can prompt an urgent CT scan, at the same time can avoid unnecessary referral for CT scans. So here comes the role of near-infrared spectroscopy. So near-infrared is, as the name suggests, it is closer to the infrared spectrum, which is red is the lowest visible spectrum to human eyes, and infrared is what we use in remote control of TV and toys. So it is 760 nanometer, a bit less than the IR what we use day to day. So peculiarity of infrared as compared to the visible spectrum of light, which cannot penetrate an object. Infrared can penetrate up to certain depth and can be absorbed depending on what it penetrates, and is reflected back depending on what it penetrates. So using this principle, hematoma can be detected. So this animation shows how it's not working. Sorry, it's not working. So okay. So what happens, light is emitted, it goes deep inside the skull and brain, and then it is reflected back. So the emitted light and reflected by light is absorbed by what lies beneath the skull. So if there's clotted blood, which is red, the most of it is absorbed and some part will be reflected back. And depending on the optical density difference between the emitted light and reflected back light, we can detect intracranial hematoma. So a number of devices are already available since 1997, And variable sensitivity and specificity studies have been done. So these are the high class studies which shows the sensitivity of the number of devices already available ranges from 74 to 93% sensitivity. And so in terms of specificity, it's not so specific. That it can be as low as 30% to as high as 90%. So there is continuous improvement in the device, not only in terms of penetration, but also now with modern machine language paradigm. You can try to detect more and more hematomas at the same time, avoid false positives. So one such device was developed in India, and we have done clinical validation studies at 3 centers, one in southern part of the country, central India, and western India. And sensitivity was found ranging from 90 to 96%, and specificity 90 to 97%. So this is the sensitivity of infrared-based detection of intracranial hematoma. But what about false negatives? Sometimes it can have false negatives. That means there is hematoma, but the device does not detect. As I mentioned you, it measures the optical density difference between sides, right and left side. So if the hematoma is bilaterally symmetrical, there will not be any OD difference, and it will tell there is no hematoma. If the hematoma is too small, again, because the area scanned is hardly some 3 centimeters square, so it cannot detect. If the hematoma is too deep, like this splenial hematoma and diffuse axonal injury, it cannot detect. And if the patient is moving too much, because it needs to be remain in contact with patient for few seconds, so it cannot detect. And during transportation, like in ambulance on our Indian roads, there will be a lot of movement. So patient will not remain stable, and sometimes it may not be able to detect. So second question, which is oftenly asked when an NIRS device is used or demonstrated, what is the evidence that the use of NIRS impacts diagnostic and or therapeutic decision making for patients suspected to have brain hematoma or with risk for brain hematoma? So there is no evidence because nobody has studied. People have studied only sensitivity and specificity, likelihood ratio and all. But with the available literature, it seems that it can a positive result, that if the device says that there is hematoma, it can prompt an urgent CT scan. So you don't waste time. Patient is conscious, but if the device shows that it is hematoma, immediately shift the patient to a center where there is a CT scan available. At the same time, when the result is negative and there are no higher risk factors according to a clinical prediction rule, there is no need to transfer patient urgently to CT scan center. But then third question, immediately a question will ask when the second comment is given, what if hematoma develops at a later stage, delayed hematoma? So one advantage is since it does not involve radiation, it can be used repeatedly, like half hourly or 1 hourly. You do GCS hourly pupillary examination. Similarly, you can use this hourly and see if the findings change. And when the findings change, at that time you can send the patient for scan. And most of the EDH, they do not increase after 8 hours of initial injury. So after 8 hours, if it still shows it is negative, then nothing to worry. The next question, what is the evidence that use of NIRS to detect brain hematoma impacts patients' outcomes? Now, again, it is not directly studied, but it is common sense that if you detect any hematoma early, the quick treatment can be given, and indirectly, the outcome will be better. So this is the advantage. What are the adverse effects? Like most of us are very well versed about radiation. We are taught about radiation in our medical school, and we know the adverse effect. But we are not taught about NIRS. So it is a non-invasive. So there are no adverse effect. It is very quick to perform within 2 to 4 minutes. It does not interfere with delivery of usual. Like by the time nurse is taking blood for routine labs, at the same time it can be performed. So it does not consume extra time for evaluation of the patient. So it's a harmless. What is the cost effectiveness? Again, nobody has directly studied the cost. But considering the cost of transport of the patient to a CT scan center in an ambulance or whatever vehicle, then cost of CT scan itself, and then when CT scan is normal, and then tell patient go back to your referring hospital or other small town. So if you accumulate all the costs, definitely NIRS based bedside detection or roadside detection is cheaper. So do the effects of NIRS vary by patient population or setting? Like all the studies are done in emergency department setting or hospital setting. There is one study available in ambulance, but not published. So, obviously, since it does not require any power supply, it does not require any trained technician, emergency medicine technician, nurse or doctor, it can be done by anyone. So it can be done in ambulance while transporting the patient, it can be done on the roadside, it can be done in field, whether it is war field or it is the sports field. Now, patient specific factors like skin color, like dark skin, it may be difficult to penetrate. If hair dye is used, then again it may not penetrate. If there is a subgaleal hematoma, it will detect false positive. When there is large scalp laceration, obviously you cannot put a device on this open wound. So these are certain limitations. Like this subgaleal hematoma, it was false positive. So that's a brief about how NIRS can be exploited in pre-hospital care, even in hospital care, where like Dr. Rubiano told about bootstrapping, the red one does not have CT scans, but the red one can definitely have this type of device, or like Dr. Rezna told about if iStat is available commercially for blood-based biomarker, that device or brain scope is available, which detects EEG signals. So this thing can be put even in this red color block what in bootstrap guideline, so that patient can be escalated to yellow color or green color depending on the findings. That's all.
Thank you. So question from the room. Yes.
Thank you. Great talk. I don't use it, and so forgive me if this is a stupid question. Seems to me that the physics would be better in children than adults, just given the small scalp, the thin scalp, the penetrance would be better. Is that true? And have any studies shown that?
Yeah. So there are 2 studies published on children with TBI, and they found more or less similar sensitivity and specificity. You expect it to be better, right? But only 2 studies, and those 2 are very small studies. And with this, our currently available Indian device, we have done a pilot study, not yet published. We are just experimenting on intraventricular hemorrhage in neonates.
Okay.
So it is able to detect IVH in neonates. Basically, because of same physics principle, the head circumference is small, so it will be able to penetrate all the way till ventricle as well.
Okay. And I'll just add, it would be great if it was, because if there's anybody you want to avoid unnecessary radiation, it's the small kids.
So that's it. So we have done study at NEMHANS. Now we have got ethics committee approval for children and elderly now recently. So we are going to commence this study in children and elderly. Besides children, elderlies are again beneficiaries, because most of the elderly patients, they have fall, very trivial fall, and if they are on antithrombotic anticoagulants, they can have huge hematomas. At the same time, it is a task because of limited mobility to transport an elderly person to the CT scan center. So in the nursing home or in the assisted living care or old age homes, if there are trivial falls, this device can go there and then detect whether there is hematoma or not. Same thing about children, they fall in school, they ground. So no need to do scan for all the children. But at the same time, parents may be apprehensive, there may be something wrong in the skull. At the same time, they don't want a radiation. So this can be used.
Thank you.
Yeah.
But Dr. Dhaval, as you told, what is your policy? First you go for the infra scan, and CT you wait for CT scan.
So the use of NIRS based detection is not included in any policy except for armed forces in USA. They use it as a policy, like in warfield and remote areas. It is being used in battlefield, but hospital setting it is not being used as a policy.
Okay, because it is not the surgery is important, but so many other adjuvant like anti-edema measures and anti-epileptic measures, we have to decide with CT. So how you solve this problem? Because it will not detect deep, it will not detect the bilateral. So in these cases, how you?
So this is a commonly asked question. This is not a replacement for CT scan.
Yeah.
I told you very 2 specific objectives. It can prompt early scan. At the same time, it can avoid unnecessary large number of CT scans. These are the only 2 potential indicators.
Thank you.
Can I ask a question? Thank you, Professor Shukla. Very good. Near-infrared spectroscopy I've used in post-operative monitoring for spinal cord surgery to check the vascularity and the flow. Does this actually measure vascularity or the flow, cerebral blood flow within the small arteries, or does it actually measure the hematoma in the way the signals are going in?
So NIRS are used in two contexts. The
Yeah.
one which I showed measures just the optical density difference. What you are talking about, it is an indirect measure of cerebral oximetry also,
Yes.
which is used in neurocritical care. Again, it is semi-quantitative and not quantitative.
Yeah.
So it is largely used on the both the sides,
Mhm.
and the difference can be found. So in cases of stroke particularly, in cases of AVM and AV fistula, and sometimes indirectly in cases of traumatic brain injury also, it is an indirect oximetry method. It is being used, and now NIMHANS also we use NIRs as indirect oximetry during surgeries and during endovascular treatments.
Yeah, so the interpolation of this could be in head injuries without any hematomas. Can we also study the effects of TBI without causing a hematoma? In your series in NIMHANS.
So that is we use in severely head injured patients.
Yeah, without any hematoma.
Without any hematomas are used.
And does it show better results or better predictive scores?
It's a very indirect measure of oximetry. So
oximetry, right? Okay.
And what other thing which you are talking is like FNIRS, that is called functional near infrared spectroscopy, which is similar to fMRI.
Yeah.
So there are optodes, like same like EEG, 10-20 optodes are placed on the skull. So it will measure the difference between two consecutive optodes. So depending on the brain activity, same like bold signal, this also gives indirect signal, and you can localize the function.
That is more specific. The
FNIRS is more used in rehabilitation settings rather than in acute care settings.
Thank you. Very good idea forward. Thank you, sir. Sir, Legion.
Thank you. So, another question, last burning question. Sorry, there is two lines. I didn't see.
Actually, we have completed the same study with NIMHANS team at our center also. What we propose as a triage tool in the field more of, and if we can validate that model in the hospital, and we can give certain security that in field, if you detect the hematoma, the person can be transferred to a place where the neurosurgeon is available if the facilities are limited, and it needs further investigation as everybody has discussed. And what sir was telling, that NIRS as a to detect the vascularity, we have used the NIRS in to detect the wound healing process after spine surgery or to detect any ulcers. So we have done a pilot study, and with the team we are developing certain tools so we can anticipate wound infection, and it has unlimited scope actually, NIRS.
So we can pass from the next speaker, and there is one co-chair, Professor Andres Rubiano.
The great talk from Professor Daval. We are going to mention another tool, another set of tools that can be used in this type of scenarios. So the NIRS is used mostly, as has been mentioned, for detecting blood. And now we are going to speak a little bit about two systems that will allow to understand if there is a reduced compliance inside the school. So, as was mentioned by Professor Reisner, we need to understand that if we are in different pre-hospital settings, we can define different strategies of care, and many of these tools will be very important either in advanced settings or either in basic settings, because we need to understand, depend of the time of transport, what is happening inside the school of the patient. So the neurosonology in neurotrauma has been increasing, gaining every day more evidence related to the different interventions. There are two of the techniques that have been currently associated with evaluation of intracranial pressure, or better than that, really to understand if the compliance is reduced inside the school or inside the compartments. And for that, we regularly use the transcranial Doppler, that we need to understand that is basically measuring the flow velocity of the vessels. And then we have the optic nerve sheath diameter that is looking for the distance of the dilatation of the dura mater around the optic nerve. So that means that if you have an increased area here, that means that there is something generating increased pressure inside the skull. So the first question will be, which value of optic nerve can be associated with high risk of intracranial pressure? So we have some values here. I just want to hear from the audience if we are related or correlated with that. So who vote for 6 millimeters? So raise your hand who vote for 6 millimeters as an abnormal value for ONSD. Okay, who vote for 5 millimeters? Anyone for 4 millimeters? All of them, none of them? So the technique regularly include the use of a linear probe. The linear probe with the 7.5 millimeter, 7.5 megahertz system that is regularly used for vascular ultrasound. This is the one that we use for put the central catheters, for example. And the idea is that you are gonna insonate the orbital cavity in order to evaluate posterior to the retina the distance of the optic nerve in diameter. So it all depends on the system that you are going to use. Now we have so many portable systems that can be, using the handheld, attached to a cell phone or attached to a tablet by Bluetooth, and it depends of the quality of the system that receive the information, depends of the quality of the cell phone or depends of the quality of the tablet. You are going to have different type of imaging. So the actual value that it has been recommended in order to correlate this as an abnormal exam is now proposed to be at 6 millimeters of distance. So if you have 6 millimeters of distance in the optic nerve sheet diameter, that will be something that it will be considered abnormal in most of the cases. In the technique, you need to also measure 3 millimeters behind the retina in order to have like a standardized way of measure that. The other thing that you need to take into account is the preset of the ultrasound machine. The traditional exam is performed on the thyroid gland presets, but it also can be used depend of the machine that you have. There are some machines that have presets for peripheral nerves and deep nerve, superficial nerves that can be also used that as a preset for the machine. This is an example of how you perform the measurement. So you have 3 millimeters after the retina, and then you measure the distance of the system. This is an scheme. Also, it will be very important that as much exams you perform, you really will detect the difference of the dura mater versus the nerve. It's really important because sometimes when you don't have enough experience, you measure only the nerve, but you really need to measure is the dura mater surrounded the nerve. So in order to confirm the positivity of the exam, because it's very dependent of who is performing the exam, that have been suggested that an average of at least 4 values, an axial measurement and a sagittal measurement for each eye, or an average of 3 values or 2 values has been proposed. Now has been considered that the standard way will be suggested as measuring 3 times the distance, and you will have finally the mean value of the 3 measurements that you perform during the 3 times in order to consider looking for an abnormal exam. So now here you can see very well the differentiation between the dura mater and the optic nerve. So we just finished a few months ago the international consensus for non-invasive system for measuring ICP in patients, and preparing for that exercise that we performed, we did scoping reviews in order to see what is already published, what are the different values that have been suggested, what are the different techniques that have been suggested. So I invite you, if you want to go deeper into the details for each one of the techniques, you can have access to this paper that was published, I think like a few weeks ago. We also did the same for transcranial Doppler. And interesting is that for transcranial Doppler, as this is a value of flow velocity, not really ICP, there have been some formulas that have been proposed in order to consider when is an abnormal ICP associated to the reduction in the flow velocity or also an increase in the pulsatility index, that is an index that is based also on the flow velocity differences from the middle cerebral artery and peripheral ones. So this is more complicated, but it has been considered that all the different formulas that have been proposed are not really reliable. And it was really interesting because some of the people that already published the original articles many years ago, they propose into the group discussion for the consensus that they suggest to do not use their own formulas. So this is really interesting because the people who performed the studies was suggesting that there are limitations using those formulas. So the consideration will be based solely on the pulsatility index value other than the other considered formula. So this also have been published a few weeks ago and is the scoping review for TCD. This is the one for optic nerve evaluation. So then we move to another system that is the pupillometry. The pupillometry is a machine that using specific measurements for the velocity of contraction of the pupil in the patients can evaluate the difference, very small difference that we really don't detect with the regular light exam. So we regularly try to evaluate the pupil size with a lamp, but we don't detect specifically this type of velocities. Is used also for brain death evaluation. So this is the screen. And what regularly do during the process is that they evaluate the waveform of the normal contraction of the pupil. So when you have the waveform of the normal contraction of the pupil, you have the initial contraction or the onset of the contraction, the initial size of the pupil, then you have the maximum contraction velocity point, then you have the peak of the contraction, and then the maximum dilation velocity when you are finishing the process. So all these values are represented and compared from one side to another one. And with this specific device, there are two now in the market. With this specific device, they have an index that is called the neurological pupil index or pupillary index, that when it's below 3, it has been associated with the presence of a mass or a very compromised ipsilateral compliance of the school. So this is really interesting. In this case, for example, you see here, you have a right eye with 2.8 of the index, and you have a left eye with 4.4 of the index. If you see the contraction, it's really different. It's really abnormal. You have a 24% of contraction in the right side and 42% of contraction in the left side, meaning this patient is anisochoric, and that means that in the right side, there is something that is causing a pressure over the nerve. So this is the scoping review that was also published a few weeks ago with the quantitative pupillometry. So if you want to go deeper into the details, all the analysis of the study that have been published are in these reviews. So these are the values that regularly have been evaluated: the constriction percentage of change, the pupil minimum and maxi size when you start and when you finish, the latency, that is the speed in seconds of the whole process of contraction, regularly is around 2 to 3 seconds. The constriction velocity, the maximum constriction velocity, the dilation velocity, and the pupillary index, that it will be only for some of the devices, not for all of them. This is the consensus that I think it's going to be published in a couple of months. We are finishing analyzing all the final responses. It's called ICONIC as a summary of the whole process that is monitoring TBI when invasive ICP is not available. And these are some of the examples of the recommendations. As I mentioned before, in case of using optic nerve sheath diameter, we recommend to consider a value of at least 6 millimeters as a marker of intracranial hypertension. And another important recommendation is that in the group was a general consensus for do not take action only with one device. So the idea is for the three devices that were evaluated, transcranial Doppler, pupillometry, and ultrasound of the optic nerve, you need to have at least two different systems generating an abnormal value in order to consider going for treatment of that patient. But this really open, a window for treating patients in areas that does not have access to advanced monitoring. And as has been mentioned, you can imagine how valuable can be evaluating patients even at pre-hospital level when you have patients that are with prolonged transport times, because it will be different if somebody calls you and say, okay, I have a patient that have, a positive NIRS and have an abnormal pupillometry and have an abnormal ultrasound of the eye in the same side of the pupillometry. That means you have a patient with a mass that will require urgently evacuation without using CT. So now, when we integrate many of these things, we can complete a really great scenario for a more precise decision-making point. So this means that for real world that have a lot of implications, and I think this consensus will be very valuable for areas that do not have too many resources in order to advance monitoring this patient even at the ICU level. So as has been mentioned, we are now in the update process of the bootstrap protocols, because the first edition of the bootstrap protocols were performed in 2017, were published in 2020, and many of this technology was not well understood at that time. So now the second edition of the bootstrap protocol is including all these different devices in each one of these stages. And as was mentioned by Professor Chokla, you can imagine what are the different if you are in a very low resource setting, and you can include the possibility to have NIRS evaluation for a patient. And also, as I mentioned before, even in very advanced settings, it can be very important, because if you are doing almost critical care in a very advanced transport, you can understand if your treatment is doing positive results or not. We are now in our unit, we have been using this for the last, I think, almost 7 or 6 or 8 years, is that when we, for example, give hypertonic saline as a hyperosmolar therapy in the patient, we measure optic nerve before and after putting the bolus. So we can understand if the bolus is performing some change in the compliance of the patient or not. So this is something that as much you will be using that, you will be understanding better and having, as was mentioned, a better precision medicine approach for patients, even in areas that do not have too many resources. So it can be used for pre-hospital triage, as we mentioned, but definitely will be changing soon in many of these very different scenarios that have been considered also critical when you have these very critical patients in areas that do not have too many resources, or even in these different conditions. These are some images from many of the combat-related injuries that are still present in Colombia. Fortunately, we have less than in the past because we have an important peace process many years ago. But unfortunately, because all the violence that is associated with the drug trade in Latin America, we still have areas, especially in jungle and borders with other countries, that are causing many casualties with severe TBI in these conditions. In order to finish, I just want to say thanks to many of our collaborators. We have a training program that is a global neurotrauma and international fellowship supported with the group of the University of Cambridge in our center. The fellow spent 6 months in Colombia working specifically in all these type of scenarios that we are developing this work, and the other 6 months outside in countries like Brazil, Bolivia, also United States and UK, in order to have a complete approach of how to integrate many of these critical decision-making points, improving outcome of the patients. And this is our network. We have this referral center for another around 6 to 7 small facilities. We regularly have around 1,000 patients per month, but fortunately most of them are mild TBI cases, but it really allows us to understand how all the process of care is going by. And now we have an association with the big university hospital that is right across the street from our referral center. And it has been created a unique scenario for practice and training for many of the international visitors and fellows. And this is our research center. It's located some sort of nearby. This is the panorama of the Cali city in the Pacific region of Colombia, where we are doing all this work. So thank you so much.
Thank you so much, Marcos. Any questions? I would emphasize that this kind of monitoring is not only useful in limited resources, but also in high-income countries. I use regularly the pupillometry and transparent Doppler to follow up all the patients that are monitored in invasive ICP monitoring, but where we have doubt about autoregulation. You know that we can have patients with normal ICP value or not so high ICP value, but with a much more compromised. Non-invasive ICP monitoring is useful tools also for. So we are a little bit in delay. You have a question.
Yeah, possible. Yeah, thank you, sir. A wonderful talk again on looking at the phenomena from different angles and devising point of care approaches. Have you considered OCT? Because I saw one of your graphs showing a delay in the pupillary response on one side. Is that a consequence of dysfunction? I would imagine. ICP causing retinal ischemia and damage, in which case OCT will very clearly and very quickly, through a POC device, show ischemia.
So, as much you use the techniques, you learn so many other aspects.
Yeah.
Obviously, as much tools you have, you need to use that in combination in order to understand what is really happening inside the school. So there are some conditions that affect the lecture or the reading of the pupillometry. We're going to discuss that in the practicals. And the idea is that we are working now. Corrado was part of that discussion that we have published related to the importance of many of these systems into the compliance in specific regions of the school. You know, we talk about now a compartment syndrome that can be detected by many of these tools. And a very important point for what you were mentioning is that we have, correlating this with the imaging, we have understood that sometimes if you are decreasing the compliance, you know, the velocity of the contraction is affected without being or having the nerve in touch with the tissue. Because regularly, the regular concept that we have is that in order to have affection of the velocity of the pupil is because you have a brain herniation, you know, that is generating some sort of pressure over the nerve with the brain tissue. But as you are losing compliance, the reduction of the compliance affects the velocity of the CSF that surrounds the nerve. And it also affects the velocity. So there are so many things that we are learning, and it's really interesting how we can integrate many of these techniques.
Thank you for taking time. Thank you.
Wonderful. Thank you very much. My name is Mario Gano. I'm a consultant neurosurgeon in Oxford. I'm the head of the adult neurotrauma service there. And I've been asked to basically discuss the evidence regarding pre-hospital care in neurotrauma. I do not have any conflict of interest relevant to this talk, and the key learning points for my talk will be why pre-hospital care matters, how do we embed this in neurotrauma services, how this can prevent the cascade of secondary injury, and obviously I'll be discussing in practical terms which scales we could use, how we adopt the ATLS principles, and I will guide you through the evidence that is available on spinal immobilization, indication for intubation and ventilation, and intravenous fluid. In the interest of time, I'll try to cut as much as possible because we are late, but basically what I want to point out is if we consider a patient with a major trauma, we know that they can die as a result of three time points following the major trauma. The first one is immediately, if the injury is overwhelming. However, there is a possibility that they might die in the several hours following the initial injury, or even in the weeks after that. And those are the injuries that we can eventually manage, and if treated adequately, we can reduce the mortality for traumatic brain injury. This is the helipad at Oxford, and I use this to just tell that obviously there is a wide heterogeneity across the world on how pre-hospital care is organized, and we heard this multiple times this afternoon. And whereas in high-income countries we have a very advanced level of pre-hospital care, there is still doubt on how to use the best practices learned there and move to low and middle income countries. This is a scoping review that was conducted a few years ago. In 2020, we concluded the analysis of the literature, and we proposed a matrix of unmet needs of neurotrauma services. And one of the conclusions that we provided is that obviously at the moment there is no evidence that high-income countries actually have this overwhelming superiority over low and middle-income countries. The lack of evidence is due to the fact that we do not have any randomized controlled trial comparing different systems where you have paid pre-hospital care by a professional ambulance crew versus other form of pre-hospital cares, such as having some voluntary with some basic life support training, and this lack in neurosurgical knowledge is difficult to address, because how could we possibly conduct a randomized controlled trial comparing such a different pre-hospital model? Another aspect of why it would be difficult to do so is that the mechanisms of injury for traumatic brain injury are so different across the world, and you have countries where the main mechanism of injury might be mechanical fall, and this is becoming the case in Western world, certainly where I work in Thames Valley. We have the vast majority of traumatic brain injury occurring in the elderly and resulting from either falls or low velocity mechanism of injury. Whereas this is not the case in countries like India, where road traffic accidents are becoming the first cause of TBI. This study was conducted in the Netherlands and was trying to identify some factors that might play a role in pre-hospital care. And the authors concluded that basically the GCS level, pupil reactivity, blood pressure, were the most important factors dictating clinical outcome. Interestingly enough, they did not find any difference between patients that were tubed versus patients that were not tubed for transport to the hospital. However, on analyzing their data, obviously one would argue it's difficult to compare different type of patient because some might not have reached the appropriate criteria for orotracheal intubation, and therefore it was entirely appropriate to transfer them without an intubation. And the difference in outcome obviously might also be dictated by the fact that we know even good GCS might not be able to predict terrible consequences down the line, and some patients might present with a GCS 15 at the very beginning, following a transient loss of consciousness, and then have an evolving extradural hematoma that will give radiological and clinical signs down the line only after a few hours. However, the results that they reached is pretty in line with the revised trauma score, which is based on obviously GCS, blood pressure, respiratory rate, and we know how important it is to use the revised trauma score, especially to prioritize care and avoid futile treatment of patients that already have a very low RTS at the very beginning. And it's also in keeping with the results that we have from the injury severity score. The injury severity score, it's very useful in the context of polytrauma in patients with traumatic brain injury. As you know, this is based on the abbreviated injury scale for 6 body regions, and at the bottom of this slide you can see what would be, is it working? Yeah, what would be the maximum score for the head and neck region whenever we have a bilateral involvement of deep venous sinuses, or whenever we have involvement of the internal carotid artery. Those injuries might be already irreversible. The extent of intracranial damage might be already reversible, and therefore investing resources in this patient might not lead to any other outcome than is dead. And mechanisms of injury might be very different between open and closed TBIs, and those patients we know requires very different management. And this is also dictated by the principle of ATLS, the ABCDE approach, that still remains our mainstay of pre-hospital care. The key aspect of pre-hospital care also revolve around all the management of patient in terms of immobilization, need for intubation, type of ventilation if intubated, and intravenous fluid. So I will quickly cover these and conclude my presentation to give space to the discussions. I want to point out the nexus criteria, which is relatively old but still has a very good sensitivity and sensibility, and so basically these tell us that whenever we have a patient with a good GCS, no evidence of intoxication from alcohol or drugs, no deformity, no pain on the midline on palpation of the spinous processes, no neurological deficit, the chances that this patient requires that this patient has a spinal cord injury related to spinal trauma is extremely low. Obviously, there are some situations where you might have patient with ankylosing spondylitis, DISH, and those patients might still present with a spine that has a severe injury with a high risk for instability, and at the moment they had of initial assessment they have not developed any neurological sign. They might not have any deformity because the fracture is unstable but still aligned, and therefore the nexus criteria might have some situation where it can be misleading. And this is the reason why in trauma we often go ahead with a CT trauma, and we explore all the possible area of injuries to make sure we're not missing anything. However, because many patients might not require color, At the moment, we are running a study, which is again funded by NIHR, is the spine immobilization study, which is trying to compare two different population patients that will be randomized for full immobilization and patient that will be randomized for minimal mobilization, which consists only on using either lateral sandbags and a sticker that will tell the spine not clear yet. And as a result of this randomized control trial, which as you can see here from the sample size calculation will include several thousand patients, we will be able to really tell whether at the moment we are over immobilizing patients. And this will have a lot of repercussion in terms of global health, because the results that we will be obtaining will have a good degree of external generalizability and therefore will be applicable elsewhere. The level of consciousness is very important, and I think someone before mentioned I think it was Professor Signa, mentioned the GSSP. GCSP to me is now the gold standard. I always teach to my medical students. I refer to this publication, and obviously here you can see the difference between a GCS 3 and a GCSP of 1. There is a significant difference both in terms of mortality, mortality from 70% to from 50% to 70% for the same for GCS3 versus GCSP1, and the outcome will be much worse. 70% of poor outcome versus over 90% of poor outcome on GCSP1. So certainly for all the students here, for all the fellows, I would suggest to calculate the GCSP and use this in your clinical notes, because it gives a better degree of standardization as opposed to write just a GCS and expect everybody to follow this indication. And then the last bit is about ventilation strategy. I just want to point out, yes, we might sit down all together, write clinical practice guidelines. However, they are subject to continuous revision. So for instance, whereas in the third edition, we had a clear target for hyperventilation, 25 millimeters of mercury. In the fourth edition of the guidelines, this was removed, and the indication for hyperventilation is purely to increase the cerebral blood flow and cerebral perfusion pressure, and temporizing the management of ICP while to theater for surgical evacuation of an expanding post-traumatic mass, or for removal of bone flap in case of decompressive craniectomy. And we heard this morning the importance of considering also basal cisternostomy. So this applies to the context of minimal invasive approaches or alternative to decompressive craniectomy as well. One of the conditions that I was mentioning before related to the fact that a good GCS might be misleading is certainly the token die syndrome. We can see here the wife of Liam Neeson had a skiing accident. It was in a remote region in Canada. After the initial loss of consciousness, she was entirely fine, no changes in the pupil size, until she had sudden anisocoria, drop a level of consciousness. It was already too late to transfer her to a tertiary trauma center. And this is just to tell that you might have the best pre-hospital care, but still, if you do not understand the mechanism of injury and how the secondary cascade might evolve, you might not be able to rescue patient. And this is why I always like to refer back to this paper from my boss while I was training in Verona, Professor Bricolo. When we had the initial discovery of CT scan, this allowed a massive improvement in the morbidity and mortality of patients with traumatic brain injury who presented with extradural hematomas. We are always improving our care, and I believe that improved pre-hospital care might lead to further decrease. So hopefully will be toward a decreased mortality and morbidity in the near future. However, for all those patients that will be in remote area of the world, we still need to train our neurosurgeons about the possibility of performing emergency bar holds. This is particularly important when we discuss pre-hospital care. As I said, there might be situations where you might not be able to transfer your patient with a suspected post-traumatic blood clot in time. And so this is how I like to teach to my trainees and also my nursing staff when I teach in pre-hospital care modules about the importance of studying the key entry points for those emergency bar holes. And that's all from my side. In conclusion, basically, I believe that in the future we might have better pre-hospital care only if we collaborate and if we share good practices. We need to be mindful of the application of clinical practice guidelines and make sure they are fit for purpose wherever in the world, regardless of the constraints that we might have in high resource and low resource countries. I would like to invite your submission for this special issue on TBI and chronic traumatic encephalopathy, which is chaired by myself and Professor Kibaro. And with this, I conclude. I thank you very much for your attention.
Okay, thanks you. And any comment from the ground? Otherwise, we can move to the interactive case panel. And for the second session, the further session, so we invite the moderator. Yep. So invite the moderator, Professor Agrawal, Dr. Ganao, Professor Signa, and Andrew to come here.
Any comments from the floor regarding the take-home messages from this afternoon? Who would like to open the debate?
And optic nerve sheath ultrasound. So pupillary reactivity seems to be most objective among the TCDs, again subjective, optic nerve ultrasound. But in terms of accuracy and correlation with ICP values, NPI seems to be least among all three. So what is your comment about it?
Yeah, thank you for the comment. As you mentioned, based on many of the reviews that we performed for the consensus, within the pupillometry, MPI seems to be the most accurate for that specific system. The optic nerve ultrasound also has been correlated very well in most of the studies. We have more studies from optic nerve ultrasound than for pupillometry. And the less accurate and reliable will be the TCD. There are more systems coming that we didn't mention, and because we are very focused here in the pre-hospital setting, but I think at some point it's gonna be. Now there is a system that have the possibility to evaluate the ICP waveform non-invasively. So that system is already tested in Latin America. There are going to be a couple of trials with it. And I think at some point you can imagine if you move from all these concepts that we have been discussing based only on a calculation or of the compliance, with really having the possibility of looking the waveform of the ICP since the ambulance. So we are going to have so many other systems that are going to be moving in the next coming years, plus biomarkers. I think they really are going to be the difference. And according to what has been mentioned is now, in the past, we were talking about an ICP number based on an invasive system. Now we are talking and having analysis of the compliance of the brain based like in 6 or 7 different systems. And I think the next point will be that all that will be integrated by the artificial intelligence. And definitely all that together will well rely better than any other classical prediction system that we have based on clinical data. So I think we are moving into that direction, and we are living interesting times for the TBI. I think we really, as was mentioned since the beginning and during the talk of Professor Reisner, we are moving into the precision medicine approach for TBI. That was not the case for the last 40 or 50 years. So we are entering into that zone now.
And just to continue to the answer, we use the pupillometry in several diseases, even not only in traumatic brain injury, in intracerebral hemorrhages, in subarachnoid hemorrhages, and there is different behavior. For TBI, the pupillometry has a much more positive predictive value. So that means that if the pupillometry is under 3, we know that there is something bad, that there is something that is no. So we use this and we say worst outcome in that patient. So when we see, even with the ICP value not so higher, that the pupillometry, the MPI going down, we increase our efforts and we increase our level of treatment. So the pupillometry for us can drive this kind of attitude.
Can I ask a question? Thank you. Yeah, it's for you, Professor Gano.
Yeah.
I learned a new score today, the GCSP, that I haven't incorporated as yet in my clinical practice, but does the British Society for Neurosurgeons, BSNS, have a validation for that, or is where has it been?
The SBNS
yes.
has not validated it because the validation was already done in Edinburgh. In Glasgow, sorry, in Glasgow.
Yeah,
and
so
the validation basically is the one that was used to identify basically the sensibility that I described and is reported on the GNS paper. So what I recommend my trainees always is to just use the pupillometer in order to have a quantitative assessment of the pupil size and response to light. And then with this response to subtract the value from the GCS. So say that you have a GCS 3 and only one pupil that is working, the GCSP will be 2. And if you have both pupils that are not working, the GCSP will be 1. And obviously, whenever this is something that we used to do intuitively in the past, asking our trainees what is the pupil size and reactivity. And whenever the pupils were not reacting to light, then the next question was what's their size. And if you have a patient with blown pupils that are not reacting, you already know what to do, which is most likely nothing. However, this has been formalized by the GCSP, and to me, it represents a very good way of standardizing communication between the pre-hospital team and the accepting center. And because of the topic, I thought it was important to mention this here.
Because the pupillometers have evolved quite a lot from about 25 years ago when I was doing initial studies in Parkinson's, and we used it as a test of autonomic function.
Yes.
But the handheld devices have become so very much user-friendly, so we should incorporate it as long as the sensitivity, specificity, positive predictive and negative predictive results are all lining up in the right correlation.
And
are recommended by the Americans and the Europeans, and of course by us in India.
You're right. And there are then the standard situation where even a GCSP of 1 might not be that detrimental, particularly in the context of trauma. If we have a direct facial trauma, obviously the GCSP will be 1 because we do not know what's happening to the eyes due to the direct trauma, and the situation of the brain might not be that bad after all. You're right.
So there are some, and the second question is more of a healthcare delivery question. Maybe Professor Agarwal might want to pitch in here. We have been hearing a lot about high resource countries and low resource countries and the neurosurgical management of TBI. Now, apart from I mean, I'm sure healthcare delivery systems in England, where I've also served for some time, is variable across the patch, across the country. So it is in India, because next to SMS Jaipur, I have more chance of getting hit by a car and getting quality care, whereas I was in a village some 100 miles away. The outcome would be vastly different, and same applies to Oxford and parts of America perhaps. So how do we actually classify these systems as high resource systems? May not be able to provide the client or the consumer the resource that is necessary. I mean, all places don't have that snowfield helicopter pad
Of course.
anywhere. Some of the corporate hospitals in India are also developing it. So the question is perhaps where does the world see India in regards to the stratification into a high resource, middle resource, or a low resource? And should we be actually talking about that, or is pretty much a personalized substructure about how to deliver the right healthcare depending on the local micro environment that the patient lives in? It's a bit of a healthcare delivery question, because you're part of NAFIL group, so I thought you might be able to answer those, from a population perspective than of an individual perspective.
From an external point of view, I would say that my impression would be that even in India there will be a high heterogeneity.
Extremely.
In terms of the type of healthcare that can be provided in megalopolis, like mega cities like Mumbai or Delhi, versus a very remote area of the country where there might be a poor road infrastructure and therefore long distances to cover to reach a tertiary center.
Yep.
And therefore you might have, as you say correctly, patches where there is the best type of pre-hospital system comparable to North America, and some other areas where the situation cannot be implemented, or will take several years and resources to do so. The question is the spending of those resources appropriate or not, or should we find alternatives? This is possibly my message from the talk. Which is we need to be mindful and not try to simply imitate high-income countries, but we need to try and find the good recipe wherever in the world.
Exactly.
Thank you.
Yeah. I mean, because our emergency healthcare physicians and our casualty physicians are equal partners. If not, paramedic crew is better off.
Please, we need to start the session.
Oh, sorry. Yeah.
Professor Sinha has come.
But yes, you have a good point, a very good point. Professor Sinha, I would invite you for your case presentation, if you have any. Otherwise, I will no. Andrew, would you be happy to come and present your case? Thank you.
Thank you very much again for inviting me, and a huge thank you for that question. That was thank you for that question. That was the absolute perfect segue to this chat. The title of my talk was, evidence-based guidelines in high-income country. But let me just quickly say, and I have a big smile on my face when I hear, this concept that everything is nirvana and perfect in high-income countries. It's so not true. And the heterogeneity in a high income in any country is as much in overall high income and low income. To your question, where's India classified? Well, it's like taking a picture of the Earth from Mars and saying, oh, well, things look good, but you really don't know what goes on in somebody's bedroom, do you? And I feel it's the same way about trauma care. You can say, well, this is a HIC, LIC, but you have no idea what goes on in an individual country, in an individual city. And so maybe that's not the best example I could use, but it's just a rough guide. Let me walk it back. It's an important guide for the overall system, but doesn't tell you what's happening regionally. And I think what can tell you happen in Atlanta which is a rich resource area. We are very lucky. We have resources. But as Dr. Rubiano said, the problem with when he did resource-based guidelines, there are many problems with the resources. Could there be lack of transport, geography? And I'm going to speak to personnel and the problem with the personnel, the lack of training, the lack of coordination. So let me just quickly get right onto it and say that greetings from Children's, you know about it now, no disclosures. And so let me just speak about severe TBI. And you asked for a couple of quick cases. Here's a little girl, 4-year-old female at a baseball game. This is the Corvette that was a head-end collision with her. Brianna's her name. She was severely injured, GCS of 3, pupils reactive. She arrested on the scene, resuscitated, miraculously, arrested again in the ambulance, resuscitated, been brought back, and comes to the hospital with multiple injuries. The ICS must have been as high as it can be, Mario, with all that ruptured spleen, tibial fractures. Came in with a subdural. I operated on her, evacuated the hematoma. Now the easy part was easy. It was over. We all know the easy parts of surgery. The difficult part is to come. The difficult part is the inevitable brain swelling that she's going to have. And there she is, Brianna, on a ventilator. And we use guidelines that we developed based on the pediatric guidelines from Brain Trauma Foundation, and kind of want to just say that that's a model that every hospital, I would really like to encourage every hospital to develop their own guidelines for what works with them and their resources and their personnel. This is Brianna. She survived. You can see her legs are a little bit flaccid. We didn't know at the time, but she had a spinal cord infarction from all the times of hypotension. A second case, Mario, little Avery, also 4-year-old, hit in the head, bad car accident. I started operating on her, had to stop. She was in massive DIC, did as best as I could, did the craniectomy, but quickly as I could, but not fast enough because I limited by blood products and bleeding, and she died within 24 hours. So those are my 2 quick case presentations. So again, we've spoken about TBI being a global epidemic. Let me speak a little bit more about the guidelines, because I was a huge unbeliever of guidelines. I was in the camp, please, I've done this for 20 years, don't tell me what to do. I'm not such a big fan of guidelines. I am a believer now. I've converted, and here's my story. So just remember a century ago, what's the sort of history? And you've got to look backwards where you came from. You know, we all trained, and when I trained, guidelines were just sort of coming in. We did things based on our mentors, institutional bias, your experience, and there's a lot of variability. The Brain Trauma Foundation led the charge, but there were other groups that said, you know, you can't all be right. We can't do it the Duke way, the Stanford way, the Indian way, the Bolivian way, the Colombian way. They can't all be right. We need to get best practices. This is sort of a tidal wave, if you like, of not just trauma, but healthcare in general. How about we do evidence-based guidelines? And that was sort of, we were swept up in that tidal wave. The first guidelines were the adult TBI guidelines. Here are the, can't remember, 15, 16 points that they did up on the screen. And I want you to just look at them for a second. It cannot get more basic than that. Nowhere do you see what the calcium's doing in the hippocampus 24 hours after injury, or what the biomarkers are doing, or what the GFAP. What the blood pressure should be. Should you give mannitol? Should you give barbiturates? It can be more simple than that. What I loved about this, and honestly, it was this effort that turned me on to trauma. I thought this was so well done. First of all, this committee, I just idolize what they did. They looked at the literature carefully, class 1, 2, and 3, they stratified the literature. The output was also 3-point stratified. Standards, this is what you have to do. Guidelines, probably. Options, and that's what just options are. The numbers have changed. It's now level 1, 2, and 3, but I still love the standards, guidelines, and options. So here's a couple of examples. This is trauma surgeons, pediatric trauma centers. This is with pediatric ones. No standards, some guidelines, some options. To respect the time, I'm going to get a little fast of the examples I sent of the different topics. This was pre-hospital management. Again, standard guidelines and options. Resuscitation, blood pressure, standard guidelines and options. And because this was so well accepted, we quickly adopted these changes. It changed our practice. It was monitored that, gosh, because of these, we stopped using steroids. We managed the patients so much better. And we developed guidelines for pre-hospital management. First one was in 2002, penetrating injuries, and then pediatrics. They've all been updated. This is the most recent one for pediatrics. Here are the topics that are done. It's online. Again, all of them are the 3-tiered, what you should do or shouldn't do. But let's just step back. When the first ones came out, why were there so few standards? If you add up all the first 4 that were done, there were only 38 recommendations. And of those, there were only 3 standards, 3 out of 38. And it was against the use of prophylactic anticonvulsants, steroids, and hyperventilation. And what I especially loved about this effort was that they said, okay, we don't have answers for the others. What are the key futures for future investigation? And that was done. And slowly but surely, the evidence is coming in, and these gaps are getting filled in. But the key word is slowly. And thanks to those who know a lot about statistics and methodology, like Dr. Rubiano and others, we've developed other techniques, consensus-based techniques, Delphi methods, so that until the strong, hard evidence comes in, we've got some sort of way of managing these guidelines. This was an example, the CIBIC, Seattle International Brain Injury Consensus Conference, where a number of experts gave their opinion, and they looked at various aspects of ICP monitoring, and they gave out this flow chart, and this particular one was, when can you remove an ICP monitor? And when it's red, you can't. When it's green, you can. And it's based on whether different parameters that are probably not going to go into at this time. As we all know, TBI affects every country in every world. Efforts have been made, again, thanks to Dr. Rubiano, about doing high resources, low resource things. And I've got to tell you, this is my story in a high resource thing, and I'm going to keep it short. When I look back at where we came, we started our severe TBI program about 16 years ago. There was nothing. We had all the components, but they were like building blocks. It was a mess. They were just scattered all over the floor like your kids. And that was point A. I knew we were doing wrong. I went to the different chiefs and administrators and said, you know, we need to do this properly. And so we went to point B. Point B is heaven. Now, I don't know what heaven looks like. I may never know what heaven looks like, so I Googled it. And that was the first picture that came up. So that's what Google said heaven looks like. So we started our severe TBI program. This is our mission statement: clinical excellence, accessibility, outreach, and some research. The guiding principle was evidence-based. It changed as the years went by. For example, there was a great article about the importance of nutrition. We added that. This was the initial guideline that came out that we started using to develop our guidelines, and this was our end result. As you can see, it became much more sophisticated, streamlined, and good. We had a couple of steps there for panic values when the ICP got high, what to do. And so we instituted these guidelines in our hospital. This is a busy slide. I just want you to know this. March of 2011. So in March of 2011, I went to the governing body of the hospital, our medical executive council, said to them, this is our guideline. They accepted it. The rule and the hammer was put down. If you manage severe TBI, this is the way you have to manage it. Now, if you're not going to manage it, you have to go to peer review and explain why you're not managing it. If you have a better idea, come to me, and if it's evidence-based, and the committee, and we'll put in the guideline. So it was strictly enforced. And that's the point I want to make to you, is if you have a guideline, you can't just hand out pieces of paper. You have to monitor it, and you have to enforce it. And we did that. And our hypothesis was implementation of the guideline will result in improved outcomes. So real quickly, we looked at the patients before they were instituted, after they were instituted, same group of kids, and this is what we found. That we had again, this is a HIC, a 40%, one more time, 40% improvement in mortality when we introduced the guidelines. As we've discussed, TBI is complex, and so there are many factors for that, but one of the factors, and we've had this data, the amount of time that the ICP was elevated in any particular patient was reduced, as shown on this graph, before the guidelines in gray, after the guidelines in green. So we think that that's probably the main factor. Did the survivors do better? Probably. There was a clinical improvement based on a sort of WEFM, which is like a rehab score for children, WEFM score, and there was a clinical improvement, but our N wasn't big enough to be statistically significant. So in summary, we showed that these guidelines really were effective. There were some downsides, and we stop right there. We published this in the Journal of Neurosurgery, and one of the reviewers came back to us and said, I'm not too sure that this is good. It could be the Hawthorne. Here it is. The Hawthorne effect. I don't know what the Hawthorne effect was, but basically what it is if you look at a topic, you focused on a topic, you're probably going to get better results, more or less. And I'm pleased to say that this wasn't the Hawthorne effect, because the improvement stayed consistently low for the 5 or 6 years that we followed it. As I've discussed, we're going to introduce biomarkers, and we in the process of trialing a handheld device that has been used in Scandinavia. I think I've showed these 2 slides. So in conclusion, let me say that numerous studies have demonstrated the efficacy that the introduction of standard guidelines improves the management of severe TBI. This can be in both large, rich, poor resource environments, but large and multi-institutional studies are needed to investigate many facets of this, including point of care, biomarkers, perhaps even the non-invasive techniques that were discussed previously. And with that, I say thank you.
Thank you, Andrew, for a wonderful talk, and again for reminding us the significant impact that those guidelines had in terms of mortality, and certainly the tendency to have a better outcome. Is there any question from the floor for Professor Reisner? Yes, please. Can we have the mic here on the first row?
Hi. Really nice talk, Professor Reisner. Something that you said is really, really important, and I think that falls into the hands of the chief of the services, because it's not just about the hand over the paper of the guideline to say, okay, this is the guideline we're gonna all follow. Sino it's about commitment. That you as chief, you as part of the team, you have to be sure and ensure that all your colleagues, all the people older and younger than you, follow the guideline. Explain the guideline, and not only that, but make it comprehensive, because under some lights, under some knowledge, for example, for me, is I'm younger, and I like to come to these meetings because I meet more experienced people, and I have the opportunity to ask hand to hand, next to each other, why you do this? Why not do this? And they say, no, I will try this, and it's not working because that. Okay. But you need somebody that is really, really committed to make a change. And it's hard, because I always talk with Professor Reisner, there's always resistance about new knowledge, about new implementation or some stuff. especially, I think it's in both sides. When you are more experienced, you have to be open to some changes. And when you are young, you have to open that for sure know that after residency, you don't know everything. Because when you are young, you think that this is the best way. I know everything. I know better than this guy. And sometimes it's not like that. You have to be wise enough to take all the knowledge of the people that have been in the field more time than you. And sometimes that's the thing. I mean, the guidelines, it cannot be for everybody, for every place. You have to adapt that guideline to reality. What do you have in your place? What do I lack in my place? For me, it took me 3 years to get a budget, to get a microscope, a CR. For some people, you already have that, so you have to move forward from that. But it's the commitment or improve things, to be better every day, to try to do it better every year. The statistics that you showed, it's really impressive how mortality goes lower and lower and lower. And that should be our goal as neurosurgeons. So thank you, Professor Reisner, for your talk.
Thank you.
Yes, I fully agree on this comment because basically whenever clinical guidelines is written, this is based on evidence, and obviously if you don't have certain evidence, you cannot make a statement. But there is always a part where we assess, at least for the guidelines I've written for AO spine, where we assess the feasibility of implementing a recommendation. And in order to increase the acceptance of the recommendation, make sure it can be adopted by as many people as possible, I think the most important thing is to have as much diversity and inclusion in the committee that will write the guidelines, because this will certainly increase the variability of the people within the sit at the table that will provide the recommendation to the rest of the world. Is there anything that you would like to add, Andrew?
Thank you for the opportunity. There is actually, for any of you who want to start your own guidelines in your hospital, I would strongly recommend you do that. But the key word has got to be inclusive. You really need to form your committee, but you need to get the nurses there, because they're not going to work without the nurses. You've got to get the administrators there. You've got to get your colleagues that deal with traumatic brain injury, the ICU doctors there, your neurosurgery colleagues there. Come to consensus that everything works for everybody. And once it's done, if you've got a group, and we have a quality department that monitored that these guidelines were being implemented for every patient. And for the first time, I could go to a crazy, and we did have one, a ICU doctor who was doing crazy stuff. He was using intermittent pentabar before he even elevated the head of the bed. Like you said, I couldn't go and say, hey, what the heck you doing? Before this guideline was developed. But once the MEC said, hey, that I could, he was reported by somebody else to peer review. They stopped it, and end of the story. And that's the only way you're going to improve it, is you've got to implement it, monitor it, and enforce it. And if it's going to get rid of some crazy people, they've got to stop doing what they're doing. Even if they are attendings and professors, you've got to stop that. Thank you.
And so this reminds us that we always need to be critical toward our own practice, because this is the only way to improve. We should not do things only because we were told to do so, or because we have always been doing that. We need to improve, and to move forward, we need to be open to new ideas, test them in a scientific way, and adopt if appropriate.
Thank you.
Thank you. One last question. Yeah.
You said after implementation of the guidelines, you could reduce the mortality to 40%.
Decrease to 40%.
Yeah, decrease to 40%. So what are the areas which you noticed that there was a change? I mean, the change happened. I mean, once you said that some crazy stuff one guy was doing.
Like Dr. Rubiano said, it was the personnel. Everybody is now attuned to managing TBI properly. At 3 o'clock in the morning, when the ICP went up, The nurses didn't have to spend 20 minutes figuring out if there's a problem or not and who to call. It was all on the guideline what the next step was. And that's why the time of elevated ICP was reduced. There may be other factors, but that was the most important factor. The personnel, everybody was attuned. They knew what to do. Day shift, night shift, weekend shift, nurses, doctors, everybody was for the first time on the same page. And that's what made the difference. And it was a huge difference.
Thank you.
Wonderful. I believe it would be good if we could have a group photo before moving to the hands-on session, which will conclude this Global Neuro event. So I would invite everyone on the podium for the group photo, and then we will have also